afternoon. Okay, today we'll be looking at drugs used in the management of cough. Okay, so we are looking at the respiratory system, and we're going to start by looking at drugs that are used in the management of cough. My name's Mr. Ngoma Austin, and I'm a licentiate by profession. Okay, without further ado, we would like to go straight into our discussion. So when we are looking at drugs that are used in the management of cough, we'll be looking at antitussives, mucolytics, and expectorants. Antitussives, mucolytics, and expectorant drugs are drugs that are used in the management of cough. Now, cough is a sudden and forceful release of air from the lungs, and it is often involuntary and a protective reflex. Cough is produced by the cough reflex, which is integrated in the cough center in the medulla. The initial stimulus of the cough arises in the bronchial mucosa, where irritation results in bronchoconstriction. Cough receptors, specialized stretch receptors in the trachea and bronchial trees, send vagal afferents to the cough center and trigger the cough reflex. Okay, so that is basically the mechanism of the cough. So here is what we are talking about. So firstly, we need to have stimulation of the mechano or the chemoreceptors on the throat, respiratory passage, or stretch receptors in the lungs. Now when this happens, a signal will be sent by the afferent impulses to the cough center in the medulla. Once this reaches the medulla, there will be efferent impulses via the parasympathetic and motor nerves to the diaphragm, intercostal muscles, and the lung. What will result from this? There will be an increased contraction of the diaphragmatic, abdominal, and intercostal ribs muscles, and then there will be a noisy expiration. This noisy expiration is what we are calling a cough. Okay, so it all starts from the stimulation of the mechano or chemoreceptors, or you would want to call them the irritant receptors. From there, a signal is sent to the brain. From the brain, this brain responds and sends the signal of the response back to the respiratory organs, the diaphragm, the intercostal ribs, and the muscles. Now, drug management of cough. Cough should not be suppressed indiscriminately because it is a major defense mechanism of the respiratory tract. So, in as much as you would want to be managing a cough, you want to make sure that you do not go out of your way to take the cough out completely, because this is your major defense mechanism of the respiratory tract. It has been specifically designed to protect us from inhaling harmful substances or having harmful substances reaching our lungs. There are, however, many situations in which cough does not serve as useful purpose, but may instead only annoy the patient or prevent rest and sleep. Now, this is where we want to use these three classes of cough preparations. So we have got the antitussives, expectorants, and the mucolytics. Now, antitussives. What are antitussives? These are drugs that suppress cough and produce symptomatic relief. So they're going to suppress the cough and they're going to relieve the patient. The mechanism of antitussives is that they're going to decrease the sensitivity of the cough center to the peripheral stimuli and decrease the mucosal secretions. So those chemoreceptors and the mechanoreceptors are going to be reduced. The sensitivity of those things are going to be reduced, and the secretions also are going to be suppressed by these antitussives. Okay, when the sensitivity of those two is reduced, you know that there will be less signals being sent to the brain. Less signals being sent to the brain means that there will be less signals being sent back to the respiratory system ordering a cough, and then the cough will have been suppressed. When do we use antitussives? For cough suppression of a non-productive irritating cough. So when a patient has got a non-productive irritating cough, you want to ensure that you prescribe the antitussives. Drugs with antitussive effect include the opiates and diphenhydramine. Okay? Opiates are agonists to opioid receptors. activating opioid receptors in the cough center suppresses the cough reflex. Okay, so that is a self-explanatory statement. Examples of opiates that are used for cough suppression are codeine, hydrocodone, hydromorphone, polcodeine, noscapine, and dextromethorphan. These are cough suppressants, the opiates. Okay, commonly, I'm sure we are very familiar with codeine. Antitussive action of codeine, hydromorphone, and hydrocodone occurs at doses lower than those required for analgesia. However, they produce constipation, nausea, and respiratory depression. So, you can use these drugs for analgesia as well as for cough. But for cough, you just need a low dose for them to work and suppress your cough. But you should have in mind that these are the side effects that you should expect: constipation, nausea, and respiratory depression. Dextromethorphan, noscapine, and polcodeine do not have analgesic properties and are not addictive and are less constipating and are least likely to cause respiratory depression. So these ones are much better to use when you have the option among all these antitussives. Diphenhydramine is a histamine receptor antagonist that acts centrally to decrease the sensitivity of the cough center to the afferents. So this one is simply working to reduce the sensitivity to the cough center. Expectorants. Expectorants are agents given orally to liquefy respiratory secretions and allow for their easier removal. Expectorants stimulate the production of a watery, less viscous mucus. Okay? Expectorants are given orally to liquefy respiratory secretions. So, respiratory secretions will start becoming thicker. You know that some conditions will make your mucus become thick and they'll start clogging your windpipe. So when you give expectorants, they're going to liquefy these secretions so that the ciliated cells can easily sweep them out of the respiratory tract. So we have guaifenesin, okay? This one increases the volume and reduces the viscosity of the secretion in the trachea, bronchi by increasing respiratory tract fluid. So it's going to be making this mucus more liquefied and reducing the stickiness, okay, by increasing the respiratory tract fluid. It acts directly via the GIT to stimulate the vagal reflex, okay? Acetylcholine released stimulates secretory activity in the respiratory tract via the muscarinic receptors. Okay, so this one is working on the vagal reflex, okay, in the GIT. So when the acetylcholine is released, it is going to stimulate the secretions, okay, via the respiratory tract muscarinic receptors. Near emetic doses are required for beneficial effect, and this drug is taken orally. It is available as a single drug and in combination with other drugs. Sodium potassium citrate or acetate. These ones increase bronchial secretions by osmotic actions. Ammonium salts like ammonium chloride, these ones are going to be working on gastric irritants that reflexly increase bronchial secretions, okay? Or they have the same mechanism as the guaifenesin. Mucolytics. Mucolytics liquefy the viscous tracheobronchial secretions. Expectorants, it's the bronchioles, it's the secretions in the bronchioles. The trachea and the bronchi, okay? Just like the mucolytics, we are saying, they're also liquefying these secretions in the tracheobronchial secretions, and they are designed to alter the viscosity of bronchial secretions, thereby making them easier to clear by cough or ciliary transport. Mucolytics react directly with mucus to make it more watery, resulting in the cough becoming more productive. Okay, so this is the point here. These ones are making the mucus more liquid, and then this is going to make the cough more productive because now the cilia is able to sweep out as much mucus as possible because it has become less sticky and less thick. Examples here we have bromohexine, acetylcysteine, carbocysteine, and methicystine. We use mucolytics to facilitate expectoration of sputum in conditions such as cystic fibrosis and COPD, chronic obstructive pulmonary disease, which is a more common condition in our setting. Cystic fibrosis is more of the white man's, or more of the British conditions. Acetylcysteine, carbocysteine, and methicystine, their mechanism of action. These ones reduce the viscosity of mucus and sputum by cleaving disulfide bonds in the mucoproteins contained in them. Okay? Acetylcysteine is given by inhalation, while carbocysteine and methicystine are given orally. Bromohexine, on the other hand, the mechanism of action is by thinning and fragmentation of mucopolysaccharide fibers. Then we also have antihistamines. These ones are added to antitussives or expectorant formulations. Due to the sedative and antimuscarinic actions, they produce relief in cough but lack selectivity for the cough center. So these ones are basically used for the sedative and muscarinic actions. As you administer these cough formulations, you need to ensure that your patient is getting enough rest. So the sedation there is being used to help our patient. They do not have expectorant action. Okay, so they do not liquefy the mucus, they do not make it any watery. Okay, the antimuscarinic effect results in thickening of the secretions. So it's quite the opposite, really, with these ones. These ones are suitable for allergic cough, not for asthma. Thicken the mucus in asthma, and this worsens the obstruction in the bronchioles. That is why we're not going to be using such things in asthma, because asthma already has thick mucus, so we do not want to worsen the condition. The examples here we have a chlorpheniramine, commonly known as Piriton, okay, diphenhydramine, and promethazine. Okay, so that is about cough drugs acting on cough. Okay, so we end our lesson here. The next time we meet, we'll be looking at drugs working on bronchial asthma. Okay, thank you for your time. Hope you have a wonderful day or evening, depending on what time you'll be viewing this video.